Scott Brown's Rhinology, Chapter 91, Allergic Rhinitis. Today we're going to learn about the treatment, children with rhinitis, pregnancy, and references. Treatment. The prevention of allergic rhinitis, methods of reducing allergen exposure, pharmacological treatment of allergic rhinitis, immunotherapy for allergic rhinitis, surgical treatment, complementary therapies. The prevention of allergic rhinitis. Various areas have been examined to determine if sensitization can be reduced in infancy. No definite triggers have been found, but recommendations have been made on the available evidence. It has been advised that children should breastfeed for at least the first 3 months after birth, that there is no benefit in having a reduced antigen diet for the mother in pregnancy and during lactation, and that the parents should not smoke in pregnancy or near children. Although no definite link with allergy has been found, there was also limited evidence of benefit in reducing exposure to house dust mite, but no definite benefit in exposing children to furry pets. Reducing allergen exposure. As the clinical effects of allergic rhinitis are caused by allergens, it would seem logical that reduced exposure would benefit symptoms. The major allergens to be found indoors are the house dust mite, cat, dog, and other furry animals, cockroach, and moles. Outdoors, the main allergens are the airborne pollens, which vary during the year and depend on local conditions. In Europe, tree pollen is found during the spring, grass and weed pollens during the summer, and various mold spores during the summer and autumn. In North America, rate weed sensitivity is a common problem, but that is not found in Europe. Tropical areas will have less seasonal variation. Methods to achieve allergen reduction. House dust mite allergen reduction aims to reduce the amount of mite allergens in the home. Wash bedding regularly every 1 to 2 weeks at 50 to 55 to 60 degrees Celsius to kill mites. Washing with cold water removes 90% of mite allergens. Washing at 55 to 60 degree kills mites. Wash pillows and duvets on hot water 55 to 60 degree and encase pillowcase and mattresses will protective with protective coverings that have a pore size of 6 mu or less. Suffice ventilation of dwellings to decrease humidity. Aim to reduce indoor relative humidity to below 50% and avoid damp housing conditions. Reproduced with permission of the WHO. Additional strategies. Use a good quality vacuum cleaner if possible, one fitted with a HEPA filter. Use a damp duster when dusting and cleaning surfaces. Replace wall to wall carpets with linoleum or wooden floors which can be wiped clean. Remove or reduce curtains and soft furnishings in the bedroom. Replace fabric covered seatings with leather or vinyl. Remove soft toys from the bedroom. Wash them at 55 to 60 degree or freeze them in a kitchen deep freezer to kill house mites. Exposure of mattresses, rugs, and carpets to direct strong sunlight for more than 3 hours kills mites and can be used in appropriate regions. Pollen avoidance provides mechanical barriers to pollen contact. Keep windows closed at peak pollen times. Wear glasses or sunglasses to help prevent pollens entering the eyes. Consider wearing a mask over the nose and mouth to prevent inhalation of pollens at peak time. Use air conditioning when possible. Install car pollen filters where possible. Pet allergen avoidance: reduce the amount of pet allergen indoors. If possible, find another home for the pet and do not introduce new animals into the home. If the pet is not removed from the home, then exclude pets from bedrooms and, if possible, keep pets outdoors. Vacuum carpets, mattress, and upholstery regularly. Change clothes before going to school or work if you have had contact with any animal, example horse, cat, or dog. Cockroach allergen avoidance involves removing the cockroaches, eliminating the places and conditions in which they can live, and removing all allergens. Eradicate cockroaches with appropriate insecticidal bait, seal cracks in the floor and ceilings, enclose all foods, do not wash and do not store waste in the home, scrub floors with water and detergent to remove the allergens. Mold allergen avoidance aims to prevent mold from growing and mold spores from becoming airborne during mold removal. Use dehumidifiers in the home if relative humidity is consistently high above 50%. Ensure heating, ventilation, or air conditioning systems are properly maintained. Use 5% ammonia solution to remove mold from bathrooms and other contaminated surfaces. Replace carpets with hard flooring and replace wallpaper with paint. Repair indoor water damage immediately. Unfortunately, despite these measures, it is difficult to achieve significant allergen reduction or elimination, and clinical benefit from these strategies has been limited. For example, a study looking at the results of using impermeable covers on mattresses and pillow demonstrated a reduction in dust mite allergen to 30% of the initial level but found no evidence of clinical benefit. Table 91.1 summarizes the evidence of efficacy for some of these measures. Although the evidence base for recommending allergen reduction is poor, it may nevertheless benefit some patients, and a trial of avoidance may be useful. Food allergy. It is unusual for food allergy to cause isolated nasal symptoms, although the nose may be involved in more generalized systemic reactions. Foods such as peanuts, nuts, shellfish, fish, and fruit such as strawberry may be involved. Milk and egg allergy is more common in younger children, but usually resolves by 4 to 6 years old. Table 91.1 Effect of allergen on allergen levels and evidence of clinical basis. Measure evidence of effect on allergen levels, evidence of clinical benefit. House dust mite encase bedding in impermeable covers, some none in adults and some in children. Wash bedding on a hot cycle 55 to 60 degrees, some none evidence. Replace carpets with hard flooring, some benefit. Ecarcidates and tannic acid, weak. Minimize objects that accumulate dust, none. Vacuum cleaners with integral HEPA filter and double thickness bags, weak. Remove hot wash or freeze the soft toys, none. Pets: remove cat dog from the home, week. Keep pet from main living areas or bedroom, week. HEPA filter air cleaners, some. Wash pet, week. Replace carpets with hard flooring, none. Vacuum cleaners with integral HPEA filter and double thickness bag, none. Skin prick testing or IgE levels can confirm a true allergen but may give false positivity results, therefore, should be targeted at specific allergens rather than having a screening role. Avoidance of allergic foods may be difficult, particularly in case of peanut allergen, which may be found in many processed food, and suitable substitutes may be found to avoid dietary insufficiency and consequent malnutrition. True food allergy should not be confused with oral allergy syndrome, where there is a cross reactivity with the pollen allergen and which is relatively common. Pharmacological treatment of allergic rhinitis. The basic summary of recommendations for treating according to the ARIA guidelines as shown in figure 91.3. The effects of the various medicines used are summarized in table 91.2. The most widely used and effective medications to treat allergic rhinitis are oral or topical antihistamines and topical nasal steroids. It should be stressed that these medicines aim to achieve improved symptom control and not for a cure for allergy. They generally need to be taken for as long as there is an allergen exposure causing symptoms. Symptom control is better for patients with intermittent allergic rhinitis if they start treatment prior to exposure to the allergen to which they are sensitized. For example, the patients with grass pollen allergy should be advised to start recommend a month before the pollen season starts to avoid the allergy development of symptoms and nasal inflammation and to stop treatment at the end of the season. In keeping with the idea of the unified airway, allergic airway, treatment for asthma may also be required, whether this be long term or to manage wheeze only during peak pollen season. Peak seasonal wheeze treatment of the nose with topical steroids reduce asthma symptoms and treatment of the lungs may reduce nasal symptoms. Therefore, symptom control will be better if both nose and lungs are assessed and treated together in a symptomatic patient. Antihistamines. The symptoms of running, sneezing, and nasal and eye itching are histamine driven, and antihistamines are the first line of treatment for these symptoms in patients who have no problem with nasal obstruction. They have little effect on nasal blockage. The older first generation antihistamines, chlorpheniramine, diphenhydramine, are rarely used now due to their sedative effects, though ketotifen may still have a role with some additional effects as mast cell stabilization. Second generation oral antihistamines such as loratadine and cetirizine are non-sedating, safe for long-term use, and can be used for children. They have a rapid onset of action, usually less than an hour, and will give symptoms reduction on a once daily dosing. Antihistamines give better symptomatic control when used regularly rather than on as required basis. Topical antihistamines, for example, acetylestin, may be used intranasally to achieve rapid symptom control and can be combined with the topical nasal steroid. It has the disadvantage of having a bitter taste that some patients dislike and needs twice daily dosing. Acetylestin eye drops may also be useful in reducing ocular symptoms. Antihistamines alone may control the symptoms adequately in some patients, though many will require addition of a topical nasal steroids. Figure 91.3 Allergic Rhinitis Management Algorithm of ARAIA Update Recommendation 2088. Diagnosis of allergic rhinitis, intermittent symptoms, persistent symptoms. Check for asthma, especially in patients with severe or persistent rhinitis. Intermittent symptoms, mild, moderate, mild, not in preferred order, oral H1 blocker or intranasal H1 blocker and or decongestant or LTRA. Moderate symptoms, not in preferred order, oral H1 blocker or intranasal H1 blocker and or decongestant or intranasal CS or LTRA or Chromon. In persistent rhinitis, review the patient after 2 to 4 weeks. If failure, step up. If improved, continue for 1 month. Persistent symptoms, mild, continue the same. Persistent, moderate to severe. In preferred order, intranasal corticosteroids, H1 blocker or LTRA. Review the patient after 2 to 4 weeks. Improved, step down and continue the treatment for more than 1 month. Failure, review diagnosis, review compliance, query infections and or other causes. Add or increase intranasal corticosteroid dose, rhinorrhea, and add ipratropium, blockage, add decongestant, and oral corticosteroids in short term. Failure, refer to a specialist. Allergen and irritant avoidance may be appropriate. If conjunctivitis, add oral H1 blocker or intraocular H1 blocker or intraocular chromon or saline. Consider specific immunotherapy. Pharmacological treatments and their effects in allergic rhinitis. Sodium chromoglycate, itching sneeze plus discharge plus blockage plus or minus impaired smell minus. Oral antihistamines, itching or sneezing plus discharge plus blockage plus or minus impaired smell minus. Ipratropium bromide, itch or sneezing negative, discharge plus blockage negative, impaired smell negative. Topical decongestants, itching or sneezing negative, discharge negative, blockage plus impaired smell minus. Topical corticosteroids, itch or sneeze plus discharge plus blockage plus impaired smell plus. Oral corticosteroids, itch or sneeze plus discharge plus blockage plus impaired smell plus. Anti-leukotrienes, itch or sneeze negative, discharge plus blockage plus impaired smell plus or minus. Intranasal glucocorticoid steroids. Glucocorticosteroids are most effective treatment for allergic rhinoconjunctivitis. Topical use in the form of a spray or drops is preferred to oral use to reduce side effects, although occasionally oral steroids may be useful. Intranasal application allows a high concentration of the active drug to be delivered to the nasal mucosa with minimal systemic absorption. The drugs reduce all symptoms of allergic rhinitis and ocular symptoms and are the first line of treatment of choice for in patients who complain of nasal block. As steroids have an effect on the production of pro-inflammatory mediators within the cell nucleus, their effect is slow to occur and long lasting. Most steroids will not have an appreciable effect on symptoms for several hours or days, and it can take 2 weeks for full benefits to be noticed. Patients should be warned of this as some will give up on treatment if it does not work rapidly. Side effects of intranasal steroids are few but include epistaxis. This may be caused by incorrect use of the spray delivery system causing trauma, as there is no evidence of nasal mucosal atrophy even with long term use. The systemic bioavailability of these drugs is low. Minor growth retardation has been noted in children treated with intranasal beclomethasone. But this has not been shown with fluticasone or mometasone. These drugs are generally relatively cheap and in many countries have been bought without prescription. Systemic glucocorticosteroids. Oral steroids may occasionally be useful in patients with severe symptoms to allow reduction of mucosal swelling and subsequent use of topical medication, or to cover a short period when symptoms control is particularly bad. Prednisolone 20 to 40 mg per day is normally sufficient, but oral steroids may cause serious side effects, so their use should be considered carefully and length of time treatment be kept as short as possible. For this reason, depot injectable steroids, while effective at symptom control, are not recommended as once injected, their effects cannot be stopped. Leukotriene receptor antagonists LTRAS. Cystinyl leukotrienes are a family of eicosanoid inflammatory mediators LTC4, LTD4, and LTE4 produced in leukotrienes mast cells, eosinophils, basophils, and macrophages by the oxidation of arachidonic acid by the enzyme arachidonate 5 lipooxygenase. Their effects are to cause bronchoconstriction, increase vascular permeability, and attract inflammatory cells, and as such are involved in the processes underlying asthma and allergic rhinitis. In the UK, montelukast, a leukotriene receptor antagonist, is licensed for the treatment of allergic rhinitis associated with asthma. In studies, it was found to be as effective as loratadine in reducing nasal symptoms, but less effective than a topical nasal steroid. Combined use of cetirizine and montelukast was shown not to improve symptoms and control above each drug individually in one study, but it to be more effective when combined in another. There is a significant variation in responsiveness to LTRAs, and a closely monitored trial of treatment may be useful in some patients. It is now has a place in the updated ARAIIA treatment guidelines. Sodium chromoglycate. Sodium chromoglycate nasal spray has modest effects on rhinitis symptoms but must be used 4 times daily, which limits compliance. It has no side effects and can be used on young children. Chromoglycate eye drops can be effective against ocular itching. Decongestants. Topical example xylometazole, and systemic decongestants, example pseudoephedrine, are available and have a place in allergic rhinitis management. The topical decongestants are more effective and have a more rapid onset of action. They reduce nasal obstruction and may allow access to a topical steroid into an otherwise obstructed nose. The disadvantage of rebound vasodilation when their use is stopped, leading to a worsening of symptoms and of rhinitis medicamentosa with long term use. A maximum length of treatment of 7 to 10 days, therefore, is advised. Systemic decongestants may also have side effects such as insomnia, tachycardia, and tremor. Ipratropium Topical ipratropium bromide spray is effective at controlling watery rhinorrhea and can be useful addition to a topical steroid if rhinorrhea is not being well controlled. Side effects are infrequent but include prosthetic symptoms and worsening of glaucoma. Nasal douching. Saline nasal douches may help with symptom control and can physically remove an allergen from the nasal mucosa. If pollen levels are high, regular douching may be of benefit. Immunotherapy. Immunotherapy, sometimes called desensitization, is a method of inducing tolerance to an allergen and therefore reducing unwanted symptoms. It can reduce the symptoms of allergic rhinitis, offer long lasting reduction of symptoms even when treatment has stopped, and can prevent the progression of allergic rhinitis. It involves repeated exposure to the patient to the allergen, usually not all but not always, with a gradual increase in allergic dose. It can be given subcutaneously by injection STIT or sublingually in drops or tablets SLIT. Studies have shown similar efficacy for SCIT and SLIT. It is effective in reducing symptoms in adults and older children, though the results are less clear for children under 5. There are several guidelines regarding the selection of patients and treatment protocols, one of which is published by the British Society for Allergy and Clinical Immunology. Immunotherapy use in the UK is limited but is widely used elsewhere. Patients considered are those who have severe symptoms but whose response to standard medical treatment has been unsatisfactory, or those patients who have unacceptable side effects from their medication. This group may be larger than the generally supposed to be, up to 40% of patients in UK general practice stating that symptom control of their rhinitis were poor. The diagnosis of IgE mediated response should be confirmed by skin prick tests and or measurement of IgE levels before treatment and correlated with the patient's history to ensure the correct allergen is used. The main allergen used in Europe are for the main Causes of allergic rhinitis: house dust mite, grass pollen, cat, dog, and tree pollen. These extracts are all available in standardized dose. Treatment is usually continued for a 3-year period to achieve a long lasting tolerance after the treatment has stopped. Recent exposure of the nose to an allergen may lead to a asymptomatic eosinophil infiltration and a pro-inflammatory mucosal environment, a concept known as priming. Such changes are likely to be reflected in the bone marrow also, with an increased production of allergy associated cellular and biochemical mediators which are effective systemically. This can cause a patient who has specific IgE to an allergen but no clinical allergy to be primed, and who will subsequently react clinically to an allergen to which they would not normally react. For example, a patient with IgE to dog and grass pollen may not normally have allergic response to either, but if the exposed dog will then show an allergic response to grass pollen late in the season. This explains why immunotherapy treatment for one allergen may have a beneficial effect for others. Efficacy: with good patient selection, immunotherapy can be very effective. In a study of patients with grass pollen sensitivity treated with SCIT over the peak pollen season, mean symptom and medication scores were 32% and 41% lower respectively than those in a placebo group. And these results or better have been replicated in many other studies. Immunotherapy for older children with allergic rhinitis also reduces the risk of developing allergic asthma later in life and of developing new allergies. Procedure and side effects: with SCIT, there is usually an updosing phase of between 2 to 4 months where the dose of an allergen is gradually increased to the maintenance dose. This maintenance dose is then injected every 4 to 6 weeks for a 3-year period. The SLIT may be updosed, or in some treatment protocols, the patient starts with the maximum dose and continues with this daily for 3 years, giving the patient a product of to which they are known to be sensitized carriers. The risk of side effects: these are usually transient redness and itching around an injection site or oral itching, and can be reduced by pre-treatment with an oral antihistamine. Very occasionally, patients may suffer a generalized reaction such as urticaria, bronchoconstriction, and anaphylaxis, and resuscitation facilities with adrenaline must be available. Almost all reactions will occur within 30 minutes of treatment. Therefore, patients should be observed for an hour after injection. SLIT should be taken under medical supervision for the first dose, but can be then be taken by the patient at home if they do not react severely. Anti-IgE antibody omalizumab. Omalizumab is a monoclonal antibody that binds to circulating IgE, preventing it from binding to mast cells and causing degranulation. Omalizumab reduces all the nasal symptoms and improves asthma control, but has the risk of causing anaphylaxis and is expensive. It is administered by monthly injection. Currently, it is recommended only for patients with severe allergic asthma with or without rhinitis symptoms. Surgery. Surgery cannot cure allergy but can give relief of nasal blockage if other methods fail. Reduction of submucosal fibrotic tissue on the inferior terminates that has developed due to long-standing inflammatory changes may improve the airway and allow access for topical nasal steroids. If the nose remains congested even after the application of decongestant in clinic, then surgery should be considered as the mucosal swelling may be fixed. Polypoidal mucosa may also be found in some patients with severe allergic rhinitis, and occasionally this needs to be removed. Complementary treatments. Trials of homeopathy, acupuncture, and herbal remedies have not shown any evidence of beneficial effect in allergic rhinitis, but many patients use them and are satisfied with their results. Key points: although allergen avoidance seems logical, there is minimal evidence of beneficial effect. Food allergies do not present with isolated allergic rhinitis. Antihistamines and topical nasal steroids are the main treatments for allergic rhinitis. Antihistamines work better if used regularly rather than on demand. Leukotriene receptor antagonists may be useful. Immunotherapy is highly effective, but access to treatment is limited. Reduction surgery to the inferior turbinates may be of use occasionally. Children with rhinitis. Allergic rhinitis is the most prevalent allergic disease in children and can have significant effects on child's quality of life. It may exacerbate other allergic diseases such as asthma. Young children may get frequent episodes of acute and infective rhinitis in a year, and it can be difficult to differentiate these from allergies. If the episodes last more than 2 weeks and are associated with other allergic symptoms such as itching, then allergy should be considered. In children with nasal obstruction but healthy nasal mucosa and clear antidiarrheas, then adenoid hypertrophy may be present. Skin prick testing may be performed on young children, though some will not tolerate it. It can be done on skin of back rather than the forearm if the children is afraid of the lancet. The treatment and algorithm is similar to that for the adults, but it may be more difficult to get children to use a nasal spray. As many of these children also have asthma, however, they may be used to using an inhaler. Oral non sedating antihistamines are the standard first line treatment, but a trial of leukotriene receptor antagonists should also be considered if a nasal spray is not tolerated or if the steroid load is excessive. Fluticasone from 4 years old and mometasone and triamcinolone from 6 years old and low systemic bioavailability and are the steroids of choice. As with adults, depot steroids are not recommended. Growth should be monitored if the child is already using steroids, such as inhaled steroids for asthma and steroid creams for eczema. Although there is no evidence of an effect on the hypothalamic pituitary adrenal axis with normal doses, beclomethasone has been associated with growth retardation and is not recommended for children. SCIT is generally not recommended for children under 5 years, though SLIT may be used increasingly in the future. Its efficacy in children is, however, still uncertain. Pregnancy. Rhinitis of pregnancy is relatively common and probably caused by high levels of estrogen. It may occur in women without any past history of rhinitis, allergic or otherwise. Symptoms of allergic rhinitis may also be exacerbated during pregnancy, probably by the same cause. Although topical nasal steroids with low bioavailability are relatively safe, hypertonic saline douches or occasional use of topical decongestants may be preferable. The condition is self limiting and resolves rapidly following childbirth. Best clinical practice. Advice to reduce allergic exposure in high risk families has not been shown to be effective in reducing prevalence of allergy. Avoidance of parental smoking during pregnancy and childhood is probably important, though evidence is lacking. Breastfeeding is recommended. Although allergen avoidance is desirable, it is frequently expensive, time consuming, impractical, and, or in case of pollens, not feasible. Recent trials and meta analysis have failed to demonstrate efficacy of house dust mite avoidance or reduction methods in adults with persistent rhinitis and asthma. Patients with allergic rhinitis and or asthma who are sensitive to cats, dogs should be advised to remove the animals, not replace them, or at minimum keep them out of the bedroom. Food allergy almost never causes isolated nasal symptoms. Antihistamines all rapidly relieve itching and sneezing but have minimal effect on block. Antihistamines appear to be more effective if used regularly. Topical glucocorticoids are the most effective treatment for rhinitis, especially if started prior to allergen response exposure. There is no difference in efficacy between the various topical glucocorticoid preparations, but fluticasone and mometasone have the lowest systemic bioavailability and therefore should be considered in pediatric practice and patients inhaled or cutaneous steroids. Specific immunotherapy is highly effective and may prevent developing of future allergic disease. Future research. Should allergen avoidance methods be used in patients to prevent the development of allergy in children? What effect does it have? Should occupational allergen avoidance methods be used? Should patients with allergic rhinitis and or conjunctivitis use antihistamines, glucocorticosteroids, anti-leukotrienes, chromones, decongestants, or ipratropium bromide? What is the effective relative effect of these medications? Can decongestants be used long term if used with a nasal steroid? For what period and how regularly they be used? Should allergen specific immunotherapy be used in patients with allergic rhinitis? What is the effect of subcutaneous and sublingual specific immunotherapy? Do complementary and alternative treatments for allergic rhinitis have an effect? Should medications for allergic rhinitis be used in patients with concomitant asthma and for the treatment of symptoms of asthma? What is the role of helminths in the development of allergic diseases? Key points. Allergic rhinitis is best considered in the context of unified airway, allergic airway, or even as a systemic disease. Diagnosis is best based on the symptomatic presentation, exposure, and evidence of allergen sensitization. The disease has a strong association with asthma and an underestimated prevalence, cause, and impact on quality of life. The mainstay of contemporary treatment are avoidance of allergen, oral or topical antihistamines, and topical corticosteroids, but immunotherapy has a re emerging role. Thank you.